Welcome to the Two a Kidney podcast. You're with Mon and Don.
Two advanced practice nurses with decades of experience in hard-to-heal wounds, burrowing into prickly conversations.
Well, welcome back to the Two a Kidney Wound podcast. This is Donna Nair and I'm with Monica Samowick.
Yeah.
And we're really pleased to be back, bringing you more prickly topics as we unpack contemporary wound care, wound management, and all those periphery topics as well. We wanted to kick off this first part of the episode by just actually acknowledging everyone who's listening. We have received so much feedback. We are so encouraged, aren't we?
Yeah.
And we wanted to just say thank you because it's been, we're 7 episodes in, this is episode 8. And, not only the emails and the DMs, but also the people that have come up to us who know us and don't know us, I think. I've had a combination of both.
Yep, true.
Yeah, have you? Who have just said, I'm really loving the podcast and I really can't wait for more. And also there's been some really great clinical questions. We can't obviously get to all of them, but it's important we just wanted to acknowledge that we know so far we've just skimmed over the top of a lot of topics.
Yeah.
And if it's been prickly, if you've had questions, we feel as though we're hitting the right spot. Not quite mission accomplished, but that's exactly what we want to happen. We want people to be able to question, and you before, Monica, have said, be confident to be unconfident.
Yeah.
And it's about that learning journey. So thank you very much to everyone who's done that. Please don't stop asking us questions, and we will take deeper dives into a lot of that. And your feedback helps us do that, so we're hitting the right mark. Did you want to add anything further?
No,
to that,
I think I've been surprised at the people who've approached me and given me feedback in some very random places. And we've just recently been to a workshop conference where people were coming up to me and providing, of course, face-to-face, they're going to provide us with positive feedback. We've had some other feedback that has been really good. It's been constructive, and we'll be working with that.
Totally.
It's been strange. And, you've got more of a profile on social media than I do, and I've got to work on that. So people don't really recognise me, and it's often they approach you and you go, here's Mon as well.
Absolutely. It's been great to meet new people as well. I've really loved that, reaching out and reaching new people who might not have been around that wound space.
Yeah.
It's really great. So we love it. So please don't hold back and come and say hi to us.
Yes.
And certainly reach out. We're contactable. So what are we going to do for this episode 8?
Well, I'm looking at my list.
Our growing list.
Yeah, because it's been a long time between drinks, really, recording the first series of podcasts to now. And we've created quite a long list. And so we're deciding this morning what are we going to do. And we've decided, I think, we talk about the unhealable wound and what is an unhealable wound. They've tried to define it in the pressure injury specialty or domain, but when I think about it, and I'll stop in a moment, but when I think about it, I think each one of us, if we're asked what do you believe to be an unhealable wound, we'll have very different questions. And if you are a novice clinician, if you're, for example, a novice nurse or a nurse practitioner, your answers may be very different to a GP or a vascular surgeon. So I think this will give us an opportunity to unpack it.
Tease some of that out.
Yeah. So what are your thoughts?
The first thing, I'll tell you what first comes to my mind is, and certainly in private practice, and as you know, I go into a lot of sectors, is one thing that people come to me quite often and say is, actually I've had it on a lot of my socials as well, you're not required, i.e. you don't need a wound consultation because your wound's not healable or their wound's not healable. Now, I think sometimes that makes me sad, firstly.
Yeah.
Because they still may be having wound concerns, wound issues, and it could be as simple as odour, smell, pain, exudate, infections, the inability to go out down to the shops and have a coffee with a friend because they can't leave the house, you know, those type of things. But also, who's decided first that it's not healable? And I just think it takes away from the additional things that we can help with. It just minimises those, when in actual fact, sometimes we'll just go in and fix those things up, even in healable wounds, and then the wound will go on to heal. So I just think that statement is, yeah, it just makes me sad in the first instance. But often there's a background kind of, and maybe I'm reading into it, oh, you're not required because it's not healable. When someone, it could be that they're getting to the end of life, but not always. It's just,
and we'll talk about what is a palliative wound.
Types. Yeah, absolutely.
Okay.
It just seems to cause people, what I observe, even in notes, when I'm reading notes and doing assessments, people, maybe this is a bit critical, seem to take a step back and say, well, that wound isn't important anymore. Now, I know the wound is not always the most important thing, and it shouldn't be the most important thing, but where there's complications from it, we can do things so it is not the most important thing at the most important times of people's lives.
Yeah.
And I just find sometimes, not everyone, I think clinicians set out to do the right thing. I find it's treated as a bit of a cop-out. Someone still may have years left, and there's things that we can do. So that's the first thing that I think of. And then, as you've said, the changes that happen in someone's skin or causing wounds, or it might be around an arterial etiology, arterial cause, where they're making active decisions and we may not be able to heal that wound. And yeah, how does that look and how does that affect their life? Because that can be absolutely devastating.
Yeah, look, I as you're talking, I'm thinking there are scenarios where the wound is healable. Mm-hmm. We've provided the person with the wound, truly given them a lot of information in the manner that they ideally receive the information. You know, we've even done that. We've done that holistic assessment about how they receive information.
And process it.
So they've got a healable wound. You've given them a fully informed choice, and that's another thing, fully informed choice and wound management, another topic.
Yes.
But fully informed choice, and they decide, no, I understand what you're saying, but I've got different goals, different priorities. There's that. Then there's what I think happens a lot, where the person's wound is labelled as unhealable when in fact it is, and then we're giving them the wrong information, and then they're making the wrong decision. And then there's, as you were saying, this hopelessness, helplessness, and I think often it's people don't know what to do. They put their hands up and they say, that's an unhealable wound. And then they talk about, they'll often label it as a palliative wound. And I remember, now when was this? This was in 2016. This is actually quite a funny story. Like, it's really weird now when I'm thinking about it. But in 2016, I heard the senior palliative care physician from Calvary Hospital in New York present on palliative wounds. And I actually raised the topic in that forum, where I found it really confronting when people would term a wound palliative when really the human being undergoes a palliative process or palliative pathway, but not the wound.
What makes the wound palliative?
Yeah.
Even a fungating lesion is not necessarily going to be what causes their death.
Yeah, and you can often debulk these tumours. But I remember him saying at the time that even after a person dies, because what I was talking about is a lot of people when they're going through that palliative process, that their wounds still heal, and they do. We know that. So when is a,
Yeah, that is so true.
But wait for it, this is what I did. I'm not joking.
Yeah.
So
I'm on the edge of my chair here just because I've not heard this story and that's really unusual.
Yeah,
So I don't know what's coming out next.
No, well then
This is the real
I
stuff.
started, doing a literature search, and I really couldn't find whether hair still grows on the skin after someone dies. And I remember him saying something like 12 to 24 hours post. So here I am at a Christmas party.
Because you have to know.
Yes. And this guy happened to be a funeral director. I thought, great, like manna from heaven. And I asked him, and he looks at me and goes, no.
No.
And, well, he hadn't experienced it. So, whether the skin... So this is more about, even though we think the body's dying, where's the skin at? And I have looked after people with end-stage disease who've had their wounds healed, and then other people, like we were discussing a case today where that person should be healing and they're not, and so you can see why people may label that person's wound as unhealable. But yeah, that's a dirty little secret of mine.
No, that's fantastic. It makes me think of all the people that you've said that I've had along the way who we've battled, struggled, whatever you want to call it, pulled out all the stops for maybe a year or two in a variety of sectors, and we've actually managed to heal or almost heal their wound, which has been, and everyone's just, including the patient, has been absolutely wrapped in the family, all the involved clinicians, with all big teams around people, and everyone's just, that's just amazing. And then unexpectedly they pass away within a really short amount of time, completely unrelated to the wound. But I've had that happen a lot. Often those are wounds that people have said are not healable.
Yeah.
And I struggle with that when, and again, we were talking earlier today in preparation for this, I have wounds where people in the team who don't really have the expertise have said, but that wound's not healable. Or do you really think it's healable, Donna?
Oh, yes.
And I know it is because I've seen it get better. And I think there's barriers to wound healing that are about, you might call them endogenous, that are about the person with the wound. But there's also those periphery, exogenous barriers to wound healing. And when you've got systems or finances, people that are working against you, and that's really complicated reasons why
systemic
that might
issues,
be. Systemic issues, that's a great term. When they're the barriers to stop a wound healing, I really ethically find that really challenging.
Yeah.
We just accept that it's not healable, and it's really hard to get everyone on the same page working towards that wound healing. But, then we haven't talked about the wounds where, as you say, the person is palliative and they clearly are on a dying trajectory, maybe not quite terminal phase, but, clearly getting close to that. I would rarely call them palliative wounds. The wound is not palliative.
Yeah, but that word is still dallied around.
Yeah.
I think even at a recent conference we went to, the subject was palliative wounds, wasn't it?
We talked a lot about, it was palliative wounds,
Yeah.
yes, palliative wounds. And yet the topic was more about the skin changes over the lifespan.
Yeah. Which I felt quite appeased by, because I was thinking, what the hell are we going to talk about palliative wounds? Like, what is a palliative wound?
And we didn't talk at all about fungating lesions or cancerous wounds, or managing those wounds that are associated with the disease process that's going to end their life. We didn't talk about those wounds. So.
And does this happen to you? I'm sure it has. I think this is a loaded question, where family come up to you and say, Mum has had these wounds for all these years, and we're really happy that she died without a wound.
Oh, yes.
That's,
Yes.
And you just get so frustrated. You think, how many other people are being labelled as having an unhealable wound? And then also...
That's a really big thing.
Yeah.
That is a really big thing.
Prickly topic. The number of times medical professionals label a wound unhealable, I think, is disproportionately high compared to some of the other professions.
Yes, actually.
And I think we've touched on a previous podcast, we were talking about the assumptions we make as amongst our clinical colleagues about the the level of and the amount of wound management they've had in their undergraduate education. So I think what we come out is a group of people, professionals, who, through just ignorance, don't know what to do. They'll dose them up with a little Careflex and then say, this wound's unhealable.
Is it that they don't know what to do? That's really challenging. Are we seeing more of them now than we used to?
I don't know.
That would be very hard to quantify.
I don't know, but also, are they unhealable because they haven't been
taught? Yeah.
Or again, I think we're going to talk about how to biopsy at a subsequent podcast, but they don't run the proper diagnostics on these wounds, and they invariably need biopsy, and that in itself, getting a GP to biopsy, and that's one thing I envy of nurse practitioners. If you can biopsy, good on you, because that is a skill that's really not being used enough.
I think it would nearly be, and we were talking about this before, more important to be able to biopsy a wound than to prescribe medications.
Yeah.
I would have more of a barrier of that in my practice.
Yeah.
For sure.
Yeah, so we don't run the proper diagnostics, or the healthcare.
Generalising.
In healthcare we don't run the proper diagnostics, the proper investigations. I'll say it again, we call everything a venous leg ulcer.
You took the words right out of my mouth.
Yeah.
And yet how do we know? How do we know when it's still not healing and you've got that therapeutic compression on and you've addressed all other factors, and yet it still is not behaving like a venous leg ulcer? So there's them. The recent summer school that we went to, it was really good to talk about skin failure and acknowledging Carolyn Carville here, that there's still a lot we don't know about how the skin behaves, and it's really good to hear about Kennedy Terminal Ulcer, Trembolly Brennan.
Yes, that was lesions. A really good presentation.
Yeah, I've looked that up before. I've known about that, but I've not heard it talked about in presentations before. So I'm just wondering if it's worth, even in our show notes, putting a bit of a link to a couple of those things.
Yes.
I do find that I've had a lot of people who will meet me at the door, say in aged care facilities, and say, look, they are palliative, they're on a trajectory, and they've just got a wound. I think it's a Kennedy Terminal Ulcer, and I don't think it necessarily is. But is it acceptable, so I'm kind of changing the topic here, is it acceptable that someone gets a pressure injury, or what looks to be a pressure injury, close to the end of life? And how do we delineate that Kennedy Terminal Ulcer versus skin failure versus pressure injury when facilities have got to document what that wound is?
Yeah.
And there's often not someone there at that particular time. I might not be able to get there for a week or two, and you can't make a judgment based on a photograph.
Yes, I think Carolyn's presentation made me really more confident to be unconfident.
Yeah, very well.
And then I had a sort of, particularly with my background in critical care, I just think, because I remember hearing about the Kennedy ulcer first off, and I'm thinking, I saw that so many times in critical care.
Have you?
Yeah.
See, I would say I've not seen one.
Oh, yeah.
Oh, that's good.
And I suppose people working predominantly in aged care would as well. The other thing is, I think you've touched on what I was going to segue into anyway, around pressure injury and skin failure and those skin changes at end of life. And I think after I've done a bit of work in that vascular space, so when I mean the word vascular, I mean arteries and veins.
Yes.
It's quickly come apparent to me that if we could perform an arterial duplex on every person in aged care, I think we'd quickly uncover all those people who are at risk of having an unhealable
Yes.
pressure injury on the heel.
On the heel. Malleoli.
Yes. Oh, on the foot.
Yep. On the foot, period. Yep.
And now I say to people, even though you think that person, they have that pressure injury and they may be close to end of life, you may still have to have an arterial duplex of their legs, because all of a sudden it'll become very evident to everyone, that good documented evidence, that person is not going to heal. They've got their 3 major vessels supplying their leg that are blocked. You ain't going to heal that wound.
Yep.
And I've been in a situation where a family was potentially litigious and that activity was completely stopped the moment we proved that wound was unhealable from the outset.
Oh, brilliant. So as a takeaway, because I'm just thinking as we're talking about all this as well, what is a good tip then if someone is saying it could be in any of those unhealable circumstances? Is it reasonable to ask, why do you believe so? Or why is that not? If we're saying something's unhealable, wouldn't that be reasonable to document the reasons why, or ask them, can you tell me why? Not to question their judgment, but we should be able to understand that.
A healthy curiosity. I think that's, yeah.
So that would be my first takeaway. Ask why.
That's good. I reckon that's really good, Donna, because it puts the accountability on the person who's labelling that wound unhealable. And I mean, we've gone down that path of pressure injury, but we really haven't done that with other wounds. Or not we, I'm talking about the global community.
Yes. And I'm just thinking about those times people come to me and say, you're not needed, it's not healable. That's actually something I can ask people. So I'm kind of telling myself too, well, why do you feel that? And why are we not needed just because it's not healable? Because they think it might not be healable.
Don't you get so frustrated? I mean, and also, the other, the opposite of that is when I find often in my quest to make sure the person with the wound and the important people in their lives are fully informed. And often it gets misunderstood as, I want to heal the wound. And I'm saying, no, all I'm doing is providing you the platter of choice. And again, even now, informed choices, theories that maybe you don't provide as much information. Again, trying to assess how much information you really give people. But
I guess you have to make a judgment call at the time.
Yeah. But for me, it's, here are the choices. I'm not saying we go on to try and heal your wound, but if you want to give it the best shot, these are your options. And you may not be able to afford these options. Well, that's it. That's off the table.
Yeah.
Or you can't travel that distance to get that diagnostic. Well, then that's off the table.
Or maybe that doesn't suit your lifestyle.
Yeah.
No problem.
Or if you're so much in pain, forget about your wound. Let's sort out, because you could have pain for, for a whole lot of other reasons. Let's work with that first before we start deciding whether your wound is healable or not. Like, just as we're talking, I'm now realising what skills I use to determine whether a wound's healable or not. But definitely people will think, I think people think, oh, that's Monica trying to heal. No. And
I actually don't like the word. Like, a lot of people will, maybe it's just in advertising, but even, we want to heal the wound. We'll get you in to see if you can heal it. I'm actually often not interested in healing as an endpoint, because there are so many more things that come first. I've got in Reminds me of, I've got an image of 2 dressings in PowerPoints that I run in education, where I talk about, is this healable or not before you start to choose dressings and, put interventions in place, because that's a really big question that should be asked early on. And I put 2 dressings up. I'm not advertising dressings. It's not even a dressing talk, but they're 2 dressings that are currently available in another country. So, which is good for me running education because people understand it. But one of them is titled Ulcer Healing Cream. And the other one's titled something very similar. The name of it escapes me now. But healing something or other. But the word healing is in the name. Now, I think our governance is much tighter in Australia, and I'm really glad we don't have products like that. But I use that as an educational tool. I put up those photos of these products and I make it very clear these are not available in Australia, and that's a good thing. Because if you were wanting to heal something and you didn't know that a wound, that your wound wasn't able to be healed for whatever, that's not one of those endogenous reasons, you're still going to want to go and purchase that product because it's labelled Ulcer Healing Cream. The actual name of it is Ulcer Healing Cream. I just find that abhorrent. It's so,
I'd like to get my hands on that.
misleading. Oh, I'll share it with you, absolutely. You could probably Google it, but I won't put a copy of it in the show notes. Okay. But look up Ulcer Healing Cream.
I sometimes wonder too whether you have a healing plan, a maintenance plan, or a palliation plan. And when I talk about palliation, I'm not talking about the wound again, I'm talking about the whole person. But the difference between, say, a healing plan and a maintenance plan for some people is there's not much difference, because you still have to manage the exudate, you still need to debride to stop the pain, you still need to compress. But often the difference, though, then is they might be in more pain if you maybe decrease the frequency of that or change the product to a more inferior product or cheaper or simpler. Yeah. They then get pain. So last week I had a conversation with a team saying, okay, absolutely, we now, and fully understandable that the care plan had changed because the person's circumstances had changed, but just be mindful that you'll be providing more pain relief, and that could very quickly tip into palliating that person for other reasons, not because of the pain relief. But
I'm really glad you've said that word maintenance, because that was actually on the tip of my tongue to bring up next. How do we label those wounds? Because my practice is I will use the word maintenance. Yeah. Even when I'm discussing, are we getting to a point where we're deciding it's not healable, perhaps we set up a maintenance plan. And I find that word is generally understood reasonably well, or that's the feedback that I get, but I will document, it's a maintenance plan, and that we're actively preventing the things. But now that you've said that, the regimes are exceptionally similar to an active plan, focused largely on comfort and choice and lifestyle. I might just say hygiene too, and mobility, because I think hygiene is where we don't give enough credit to how much comfort it can give people. But
and I just remembered we were talking about it before we started this, about the impacts of intersectionality on determining whether a wound is healable or not. Remember that prickly conversation?
Yes.
And so intersectionality, for those people who may not be so familiar with the term, is when we look at people through a series of biases and filters and stereotypes. So you could be racist or ageist, but when you start looking at people who of a different skin colour to you, different age group to you, identify as a different gender,
minority groups,
people with disability, how often are those people labelled with having an unhealable wound?
Could I go so far as to, because we haven't said this word yet, which is unusual in our podcast, how many of those people would be more likely also to be labelled non-compliant?
Oh,
Yep. We haven't had a podcast on that yet.
No.
We will have a podcast on that language. I've got a number of social clips on it. So, but I find, yes, those minority groups, they're generally the people who are more likely to be labelled.
it's not even a minority group now. It's, people of different sizes, and we just, oh boy, that would be a great PhD study. The outcomes of people who fit into those groups.
I know from a size inclusive or weight neutral framework, I've got more about those paradigms on my website. There's a lot of intersectionality in those spaces as well. So people with darker skin, colour, LGBTQI groups, and a lot of others are generally more involved in size and weight discrimination and those type of phobias. So that's a massive area.
So the definition of intersectionality from www.vic.gov.au refers to the ways in which different aspects of a person's identity can expose them to overlapping forms of discrimination and marginalisation. And so the bottom line is, if you are have brown or black coloured skin, you may identify as asexual, you have a disability, and you're of a larger body size, and you're 95 years old, you've got Buckley's. And, I contend, if you have a wound, it may be labelled unhealable.
Yeah,
I think that's something that we don't often think about. Okay, so
it's a massive topic, and I think it would be great for us to follow this up. We'll add this to our list. We can do a separate episode on unpacking some of those tips and tricks.
Yeah.
For some of those different types of wounds. That would be an episode in itself, and some of the strategies that we will use. But this is an intro to that.
In summary, I suppose, an unhealable wound, I suppose we put the call out to everyone. If you're using the term unhealable wound, or if you hear someone say to you, this is an unhealable wound, we urge you to question, is it in fact an unhealable wound? Are you really satisfied that all best practice efforts have been used to try and heal that wound? That's if the person wants that wound healed. That's the other thing.
That's a really big topic we haven't even touched on. Everyone else in the team is trying to heal it.
Yeah.
But the person's not interested in it being healed, and that's okay.
Yeah.
So we look at, isn't it interesting, I've just thought as you've been saying that, so we look at unhealed wounds as being quite negative, but maybe that's empowering for somebody.
Yeah.
Because they're not willing or don't want to, aren't interested in doing all those interventions and strategies to get it healed. But that's okay. That's their judgment call because it's their wound.
Yeah.
And then we come along and say it's unhealable. Well, maybe that's a good thing for them because it means they can do more in their life.
Yeah, so you're right.
Who are we to say that they should have a healable wound?
Yeah.
In healthcare. It's very one-way focused. It's very clinician focused.
Yeah, and often, here's another one, so we're progressing. We were about to finish and we're done a lot. Sometimes the person with the wound or the wounds will tell you they want the wound healed, but they're sure as hell acting like they're not doing anything to make that wound heal. Or when a person says, you're going to heal my wound. Yeah. Oh, the nurses are trying to heal my wound. No, the nurses are trying to help you heal your wound.
Yeah.
You, the person with the wound will be healing your wound. The team around you, and not only the nurses, but the multidisciplinary team around you are going to help you heal your wound.
Yeah, you do hear that a lot.
Yeah,
you do hear that a lot.
So is the wound healable? If the person's not willing to come along the journey, well, it's not healable. If the person is prepared to come along the journey, then it's highly likely healable if it's been assessed as healable. And if the person decides, yeah, I understand it, if I did this, this and this, it'll heal, but I don't want to do that for whatever reason, then we respect that. And then there's concordance.
We haven't touched on well-being. I think that's part of what we've been talking about, just to summarise, and I might put a document in the show notes about well-being and wounds.
Yeah.
That's quite good. That was actually mentioned at the summer school we went to last weekend as well. They did mention the well-being and wounds. It's a couple of years old now, but it's quite good.
Yeah,
do that. Yeah, so that's a really great resource if someone wants to do some more reading, professional development, and look up some of this stuff. A lot of the concepts we've talked about will be in there.
So there's also the phenomenon where people have had an absolutely exquisitely painful wound, and stay tuned. We'll be doing a topic on pain and wounds and painful wounds. But anyway, come along, do your stuff, and they're quite happy. Thank you very much. You've reduced the pain in their wounds. Frankly, they don't care about it healing. They're just happy that the wound's not painful anymore. And you go, uh-oh, you sort of have to recalibrate your thinking. But there are some strategies you can use and addressing that I've used in the past, and I still do, which I found out some people aren't very keen on the other day. Very interesting. But it's the only time where I've ever used a dressing. And for Christmas that year, the family bought me a box of that dressing for Christmas because it had done such an amazing...
Really, that's fantastic.
Yeah.
Is that for nociceptive pain?
But that's been interesting. And I've heard my colleagues say that sometimes people just love the fact that the pain's gone and then they don't care that the wound's there. In this particular case, they'd had, I think, a squamous cell carcinoma removed, and maybe there was some remnant squamous cell carcinoma around the wound, and I believe that, you can't believe, but the story that I got from the person with the wound and their family member is that the surgeon had suggested putting Ep8 inside the wound, not around the wound, and they'd been putting it there for 6 months. So now we'd had a really necrotic wound, and it was in this setting that I used this particular dressing. And yes, and then they didn't really care that it didn't heal.
It just didn't have the pain.
Yeah, it didn't have the pain. It ended up healing, but they didn't care. They were happy to live with the wound with less pain or no pain than having the pain in the wound. So,
I have a few people like that. Yeah. It's really great.
Yeah, so it's just all options are on the table.
They are. We can't box people up when it comes to these topics and make assumptions about people, I find, get you into trouble.
Yeah.
Well, this has been really illuminating for me. I've learned some things about you again.
There are more weird and wonderfuls.
Yeah. And I think it's a topic we're going to perfuse through a lot of our future episodes because, many different wound types kind of fall into this category and affect, a lot of people different ways. And we see a lot of unhealable wounds, and some we can fix and some we can't. But, it's a really emotive topic, and it's a very special area. Yeah. It's a very, very special area. So thank you for unpacking that, Mon. So what about you, Mon? Have you got any final thoughts before we finish off this episode on non-healing wounds?
Yeah, look, of course I do. I'm thinking that we only really touched on the ethics of labelling something an unhealable wound because, as we've sort of uncovered, that many times they are healable and we probably haven't done enough as a interdisciplinary team to uncover that. And I often walk away from situations feeling very compromised because you want to do as much as you can within a multidisciplinary team, but you're in some ways relatively powerless if, surgeons make decisions that they don't want to repeat, bring people back to surgery, or
Yep.
or vascular surgeons who say, oh, I did a scan a couple of years ago.
She's right.
She's right.
Yep.
Or
We had one like that this week.
yeah, or oh no, we don't need a biopsy. And so there's that almost that moral injury that we as wound consultants have when people are labelling something unhealable, and you're thinking, just it could be.
Yep.
It could be.
Yep. Do you find that just on that ethics, and another ethical part to that is, as we wrap up, I find that then very ethically challenging when I'm with the patient and their family or their main caregivers, to then have that conversation when I feel as though a medical surgical colleague has that reaction when I don't want to get to the point where I say they're wrong, and I think you've got to be very articulate and creative when we're with families. I will go to lengths not to put them in a bad light. I think that's really, really important. But I find that very challenging, and yes, moral injury, to then push further. I often do, but gee, you've got to mix your words really carefully and be very careful who you say it to. But that's really hard to push back and to empower them to do that. And sometimes we slip into that advocacy role for them, but
the frustrating thing is, as nurses, and I'm sure nurse practitioners have got a better chance of this, we can provide all the information about why we're not prepared to call that wound unhealable for all these reasons. And all it takes is for one surgeon or one medical specialist to say, no, that's not healable, that's it. It's like a fait accompli. And it's a real struggle. I mean, things are changing, absolutely, and I don't see that as much as I used to. I don't experience it as much as I used to.
I would agree with that.
But it still happens.
It does still happen, yeah.
Sometimes you're just saying, I know what I'm talking about.
Yep. I think sometimes the patient comes to us and says that, but we know that it's healable too, but they don't want to progress anything.
Yeah.
Yeah.
And but I think as clinicians we get a feel for that. We appreciate it. But when you've set up the right scenario, they're off to see either the GP or the multidisciplinary team. It's not usually multidisciplinary teams. It's usually individual clinicians.
Yes.
I mean, and that's the value of the multidisciplinary team, isn't it? Which we don't really have that much exposure to in a regional environment. And I suppose even in your work, but but it's those isolated clinicians that just make a judgment, and as we've mentioned in previous podcasts, maybe have had, if they're lucky, half an hour of wound management education over entire decades of career, and they make a call like that.
Yep.
Oh.
Yep.
Anyway, I think
we're almost done. We definitely have more to say on this topic, and we will do more on this topic. So please let us know. Just a reminder to let us know your feedback and your questions. We're findable through all the details in the show notes. And we hope you've enjoyed hearing our intro session to unhealable wounds.
Yes.
See you in the next episode.
It's been sort of a zigzag journey, but we got there.
We definitely got there. Fantastic. Thanks, everyone. See you soon. Bye.
Bye.
We are so grateful to have this opportunity to share our learnings and challenges with you today. Hopefully it has inspired you to be more curious in your clinical practice and burrow down to issues that bug you. If you liked today's episode, follow and subscribe on Spotify, YouTube and TikTok at To A Kidney.
If we were too prickly, we'd also like to know. All our contact details and links we've mentioned are in the show notes below. You can also help us by leaving a review and sharing this with your colleagues. We will see you in the next episode, and in the meantime, go forth, be curious, and burrow into some ant nests.
There'll be struggles, there'll be wounds,